Hello, my name's Marion Sloan. I'm a GP in Sheffield and also I'm a hospital practitioner in the Central Sheffield Teaching Hospitals. I've been there 30 years and during that time seen an awful lot of change. One of the best changes that's come is the recent change to look at cases where GPs can receive advice and support about the referrals to help to get a better quality referral and to consider whether a referral is necessary at all. So this video is looking at irritable bowel syndrome, and I hope by the end you'll be able to get some useful clinical tips about how to manage IBS. IBS is very common. It's something that GPs see every working day, mainly younger people, but it can be any age group. It's more women than men, and the 20 to 30-year-old young adult is the person that gets it. It can be stress related, it can be lifestyle related, it can be diet related. Now the GP is ideally placed to try and find out what's going on, because there's more to it than just the bowels. And if you read the books, it talks about form and function and frequency of the stool, but for the person who comes to see you and they're sitting in that chair, what they're bothered about is they've got to rush for the toilet, can they get on the bus, can they get off the bus in time, how many times they have to go to the toilet when they're at work, will their employer start to make remarks because they're going for breaks too frequently. It becomes quite a social issue. So they end up with the doc. They're not diseased, it's not a life-threatening condition, but it is something that makes them quite ill and not functioning very well from time to time. So it's important to get the diagnosis right. It's quite a low-risk condition, but you do have to rule out red flags. So the GP's first job is to make sure that they're not losing weight, they're not losing blood, they haven't got any underlying what we call red flags. Once you've done that, the next bit is to do a blood test. And those blood tests would include inflammatory markers, ESR, CRP, full blood count to make sure that they're not anemic, and possibly the most important of all is celiac antibodies. One of the big features of IBS is bloating. And if they're bloating, then you have to think celiac. 1% of the population is celiac, so they are there. They will be walking into your consultation room, and it's important to spot them. If you get a middle-aged lady with bloating, then you've got to think about CA125 and possibly a scan. In general, a scan isn't really necessary for IBS, but think about it. So you've done all that, you think, yeah, I've nailed this, diagnosis is IBS, then what are you going to do? So you think about tablets, but is tablets really the answer? You can think about talking therapy with the IAP team, but is that really the answer? So one of the most effective things is to refer them to the community dietitian. The referral form's on the Press portal, and provided that you've done those pre-referral tests, the community dietitians will accept the referral and they will do a very thorough dietary, lifestyle, holistic assessment of your patient and hopefully sort them out.
Hello, my name's Gillian Goddard. I'm a registered dietitian. I'm based in Sheffield. My specialist area is IBS. I've seen a lot of patients with IBS over the last probably 5 years now. When faced with a patient who you think has IBS, carry out the specific blood tests as per NICE guidance, as Dr. Sloan has just advised, and ensure that the red flag questions have been asked. Assuming bloods are all in the normal range and the patient has not been referred to secondary care, we would then recommend that you give first line advice and refer the patient to the community dietetic service. For first line advice, please ask your patient to complete a food and symptom diary with the aim for them to become aware of their own dietary and lifestyle habits. Encourage them to review their diary weekly. They may be able to start making some changes. Print off tips to help you manage your IBS symptoms and top tips for IBS patients on a waiting list, and give this to the patient. Supporting first line advice for patient is available. Please do not initiate a low FODMAP diet. It's not always necessary for every patient to follow this diet. It's not first line advice. Many patients may be able to greatly improve their symptoms by making minor changes to their dietary intake and lifestyle. There are several reasons why we do not advocate the low FODMAP diet first line. such as patients often have a poor understanding of the low FODMAP diet and can become confused and overwhelmed with conflicting information after trawling the internet and obtaining out-of-date literature. Because some patients see an improvement in their symptoms, they may continue on the diet indefinitely, when in fact the diet should only be followed for between 4 to 8 weeks. Possible negative effects of following the low FODMAP diet indefinitely is the potential reduction of healthy gut flora and a diet which is imbalanced. Reintroduction is complex and needs to be explained by a FODMAP trained dietitian. The diet may be expensive, particularly if cooking skills are poor. Failure on this diet due to inadequate support may lead to patients to seek advice from somewhere else unnecessarily and often at a cost. If constipation is the main problem, a partially explained low FODMAP diet may make things worse. Another thing to consider is anxiety and mood, as these can impact on gut symptoms. Some support can be provided by the IAP service, and patients can self-refer to this service. So in summary, ensure the patient is eating a gluten-containing diet for at least 6 weeks prior to the blood tests. The referral to the dietitian is on the CCG Press portal. Go to referrals and then to community dietetics. Ask patients to start a food and symptom diary, either handwritten or they can use the symptom tracker, which is on the IBS network site. Ask patients to review their diary, see if they can identify changes they could make. Provide tips on how to manage your IBS symptoms and top tips for IBS patients on a waiting list. Do not initiate the low FODMAP diet. Advise the patient that this may not always be necessary and will be discussed with the dietitian.
So summarising then, common problem in primary care, GPs, we've got to get it right, you mustn't miss red flags, main sources of support, IBS network, I'd really plug that one because that's patient self-help. Make sure the blood tests are done so the community dietitian referral is going to go straight through without delay, and there you have it. Even though they may have a change in form, frequency, function of their bowel, they'll end up with a perfect stool, not too hard, not too soft, just right. That's what Goldilocks says.